Today we're going to talk about common cardiopathologies. The first cardiopathology we're going to talk about is heart failure. Now it's important to know the difference between left-sided heart failure and right-sided heart failure. So for heart failure, the location for left-sided heart failure is going to be that all the fluid backs up into the lungs. For right-sided heart failure, all the fluid is going to back up into your periphery. So you can remember left lungs, LL, and right periphery. When it comes to signs and symptoms, you can identify left-sided heart failure with any symptoms that are affecting the lungs. So especially dyspnea, rales, wheezing, and a dry cough. For right-sided heart failure, your signs and symptoms are going to affect the periphery since that's where all the fluid is backing up. So some of the telltale signs, enlarged JVD, as well as peripheral edema, ascites, which is the enlargement of the stomach, and liver congestion. Some common signs and symptoms you'll see in both right and left-sided heart failure include fatigue, which will be decreased exercise tolerance, atrophy, hypotension, as well as tachycardia. Treatment for both right and left-sided heart failure includes pharmaceutical prescriptions. There's a whole list of them, so I'm only going to name a few here, and we'll get into that into another video. Some common drugs are your ACE inhibitors. Those are the ones that end in pril, such as lisinopril. Your angiotensin II receptor blockers, such as losartan. Your nitroglycerin. Your beta blockers, anything that ends in LOL, because it's really funny. And then your calcium channel blockers. Another common cardiopathology we'll cover are the difference between chronic arterial insufficiency and chronic venous insufficiency. So the cause of chronic arterial insufficiency is caused by a thrombus or an emboli, whereas chronic venous insufficiency is caused by trauma or a clot. When it comes to pain for these insufficiencies, chronic arterial insufficiency is going to be very severe pain, and the patient's going to have a lot of cramping and numbness. As far as chronic venous insufficiency, the pain is going to be minimal to moderate, and you're going to get more of a superficial pain on that vein. So pain and vein rhyme. As far as the chronic arterial insufficiency, this is where that intermittent claudication scale is going to come in handy for the therapist working with patients with these conditions. You can work a patient to a maximum tolerable pain of 3 out of 4 on that intermittent claudication scale. As far as visible skin changes you can see between chronic arterial insufficiencies and chronic venous insufficiencies, arterial insufficiencies are going to be on your lower extremities, on your calf, more on the lateral malleolus side of things, and your skin is going to look very shiny and thin and possible hair loss. As far as venous insufficiency goes, it'll be more on the medial side of your calf and your lower extremities, and you're going to have that hemosiderin staining. Another common cardiopathology is chest pain or angina, and we have two different types. We have stable angina versus unstable angina. As far as the chest pain goes, with stable angina, the pain can reduce with reduced activity and exertion. However, with unstable angina, no matter whether you're resting or you're exercising, the angina and the pain is inconsistent and random. When it comes to controlling pain for angina, in stable angina, it is easily controlled with taking nitroglycerin when the patient feels the effects and the chest pain. When it comes to unstable angina, it is very hard to control the pain. Being the good healthcare professional that you are, I bet you're wondering, is my patient a good candidate for cardiac rehab? If your patient has stable angina, yes, they are a candidate for cardiac rehab. However, if your patient has unstable angina, unfortunately, they are not a candidate for cardiac rehab.